So thank you. So assessing the training of health professionals, it raises a lot of issues, obviously. Simply just to answer to the call of generalized assessment that's fashionable these days, is it to feed into the great models of data and AI that we're going to talk about during these 2 days? Is it an issue, a strictly economic issue? Are we assessing just to make savings, or is it a necessary evil to guarantee equal access to the same level of quality everywhere in France? Would it be a democratic imperative? A lot of issues can be raised around this subject. So I was tempted earlier. Is the question well stated? I'm going to tweak it a little and add a question mark. Assessing the training of health professionals, should we do it? Question mark. And what kind of question is it? In the prism of what objectives? Is it satisfaction of patients' needs? Or in this case, to what scale? National, territorial, regional? Are there any other scales that we should find? Is it in the prism of the expectations of the populations? But these expectations can vary from one population to the other. You talk about proximity and access. I won't get back to it. Is it in the prism of expectations of students? We should assess the training so that we had students who are willing to come to these trainings, because otherwise it will be more difficult. Is it up to in the prism of respecting of organizational constraints? Should we have having trainings carried out in a certain context, whether it's university or school or nurse schools, and maybe it's more polemical in function of the objectives of the industrials who are interacting and employ a lot of these professionals, or evidently, and I'll be done with my questions, when we say trainings of professionals, health professionals, what kind of trainings are we talking about? Is it continuous training? Is it initial training? And what kind of professionals? Is it doctors or all the health professionals that contribute in one way or another to giving care? To treat such a dense topic, we're going to cut it into 3 parts. There were 3 times 12 minutes. First, assessment of the content of different trainings, assessment of the impact on the medical practices, and the modality and the technologies. How far can they go, and what are the means implemented that can have an impact on practices? And the last point, the consequences, systemic consequences of training of health professionals. So, first of all, as Isabelle LAFFONT, can you draw, give us an overview of what you have set up as dean of your university? So I'm the dean of we have paramedical trainings and doctors, so we have 4 paramedical trainings available, and we link with paramedical regional entities. So we have strong ties with the universities. In terms of direct assessment of our students, we changed a lot in medicine universities, in medical universities. We basically were looking at knowledge first. They were checking boxes first. And so now we have the revolution. We have the second cycle revolution, which is going to look into assessment of skills. Skills is the aptitudes, the abilities, the know-how, and soft skills as well. So I'm persuaded that assessment is assessment of the quality, the efficiency of relevance of the system, and systemic effects that are major, and I'll get to that later in the debate. I'm going to give you an example. There's a lot of different ways to look into this topic on the assessment of skills. We are right now We have clinical objective assessments of the reform of the second cycle. We have simulation stations for their skills in terms of know-how and soft skills. Beyond that, we're fortunate, and I'm going to get to my example. We have specific strategies. We built in Montpellier-Nîmes a training unit that's going to follow students from the second to the end of the 6th year, which is soft skills and communication. This assessment unit is fundamental. It's precious. There's a lot of unusual trainings. We have exchange of practices group. You have emotional regulation trainings, cognitive biases, mindfulness workshops. How do I question a patient? Workshops on situations. We had a lot of trainings that we built with a theater school, with the National Schools on Theaters, where it's role play, where the actors play the patient, and we train them for communication with the patient, with a family, a colleague, a head of service, with the director of a hospital, with the regional health authority, and this is assessed. We're going to assess it through efficiencies on what we give out as training, but also what is the main target of this unit is the level of empathy and we know in literature that decreases after the studies gradually, and also assessing it according to the well-being of our students. And so this kind of prism of assessment based on the student themselves and how we build and how we meet these criteria, we don't make a good doctor if we don't train them on empathy. So we change our look on assessment. Very interesting that there's been a lot of things that have been done. Have the people in the industry have anything to teach us on what could be done more to complete? I'm going to focus on the following. If this path is long and it's been enriched, as you showed it, the multiplicity and the variety of situations of health professionals requires a training during the whole professional life. And so we also see that with the therapeutic revolutions, and we're going to get to that with the emergence of AI in a massive way. The health professionals have to adapt and get trained on these tools, acquire new knowledge, new scientific knowledge, and behaviors that are different as those that you have just described, and they have to be adapted all along your professional career. So we absolutely have to get trained all along your experiences and communication. I think of and management too, which is a fundamental element. And this morning we saw that organizations of care is a great criteria of success for the quality of care. So the organization requires time, coordination, and that professionals work together in collaboration. So all these soft skills that you mentioned. So I get back to the fact of training. If it's centered more before on knowledge, and so it has this emphasis on knowledge, and de facto all these soft skills and attitudes were excluded in the end of the field of the training, and discredited and abandoned and considered secondary. But you can see today that for it to function and to deliver a quality care, you need teams that are well organized, well managed. So management is not it's not a science really. It's more by observation, exchange, and it's an acquired skill. By being a manager in companies and industrials, you can see that. And when I heard this morning that the doctors have less and less time to dedicate to their training, it's kind of worrying. It's going to require more and more hierarchization of their priorities, hierarchy of priorities. And so the field of scientific knowledge is increasing, so they have to get trained. organizational change is increasing, and so the managerial complexity and communication becomes more and more important. So you're going to have to arbitrate between those different set of priorities. So as ex-intern and young doctor, not a young, still junior doctor. On the issues of the content of training, there are two issues: the initial training and the continuous training. The content of initial training, when it's assessed, there's lacks on interprofessional cooperation and the different soft skills. Even in Montpellier, it's something that's not given out systematically to students. I'm going to speak more of what I know, the reality that I know, but we have a great reform at hand, and I think that a reform. So what is 80% of interns don't have access to their theoretical training or personal training, and so access to platforms where the classes haven't been renewed when they were created in 2015, and so the information is not updated, and so interns today, on top of their wage, they need training because they deem that university doesn't set up the right training for them, and so interns right now interns are in continuous training, and the regular doctors don't have training. So this conclusion on this first part, I'm going to a last point of Isabelle LAFFONT on the content regarding Olivia's remark on the content and how we manage this articulation and this prioritization or hierarchy of priority. As you described, what kind of change you brought already? How are they articulated in time? Because you said you have tried to set up things in the long term, which is certainly very useful. In the end, how have you done this? The question is the training of interns, and so continuous training of interns, and the management aspect. With all these trainings that are very, very scarce in medical training. For interns, my specialty in physical and readaptation medicine, we organize seminaries for junior doctors on issues of management training, emotional intelligence, which are disciplines that are not treated in medical universities, and they should be addressed at the specialty level. And this is a topic that the universities have to tackle. And so on continuous training, the missing piece is to offer in continuous training, and that's a project that I've had for a long time, and I hope it's gonna start in 2024. Is to have a certification or a university degree on management, and with elements on communication, not just for doctors or junior doctors, but also the future hospital doctors that we select, which are going to become the managers of tomorrow. And those who have been working already for a long time, who deeply need this training. And I think it should be a rule now. So Rémi Salomon, who is remotely present. So you told me that the assessment was of training was at the heart and the first issue. In what way is it as important or more important even than the demographic, which are at the forefront today? Two are linked. When we talk about medical demographics, which are at the forefront when we look at the issue of access to care, we always talk about the number of doctors, the numerous clauses, the quota. But we don't raise the issue of, in the following way. What are the doctors that we need today, and what are the doctors that we're going to need in the future? If we frame the question in that way, indeed, we lack geriatric specialists. What do we do today? What are the incentives in terms of policy to train more geriatric doctors? And then there's the needs of the population, which are not the same from one territory to the other. What is the professional exercise? So the needs of the population evolve through time. They evolve rapidly, and the way to practice medicine evolves as well. So I think you should keep in mind these two issues side by side. Trying to meet the needs of the population of today and tomorrow. What are the skills that we're going to need? How do we manage to steer the people towards these skills, the skill set? And what is today, in what way today do young doctors are going to start their practice, whether it's in the hospital or in the city? Or in both? How can we better coordinate those efforts? And so, just to finish, in the content, the theoretical content, Isabelle LAFFONT mentioned it, and I remember my studies go back. I'm not sure we have evolved a lot. We should do more. We need a more holistic approach of people, of the patient, and so introducing more humanities. And we should also tackle, we mentioned it, the ministry, prevention, the issue of public health. I consider that they're not sufficiently taught in our universities. Robert Debray, the founder of the CHU, the last step of his reform is the one of public health. We're going to have to open the hospital on the city, or show to students where the patients live, where they work, because we know that the determining factors of diseases are linked to these factors. So I think that this field of training, and we can observe that Robert Debray said that in the early 70s, 50 years ago, I think we haven't evolved a lot in this respect. So these are very general considerations and observations, but we talk about assessing training. We need to keep in mind what skill set are going to be required in the future, and how does the professional practice, what the practice that I started, and the doctors in cities that have a professional exercise and practice that is evolving. And when you're in the hospital as well, I feel a lot of young people said, I don't want to commit in a hospital career to have a linear path, career path. This is put into question. So we have to be able to rethink, to overhaul professional practice, and this should be done already at the training level, at the training stage. So public health comes often last in the choice of students of 2023. So Robert Debray hasn't been completely heard and considered. Second part, assessment in the approach of the modalities and the means and the technological means that are more modern allow us to evolve, as Rémi SALOMON said, the practices, first the training, and then with the hope that it trickles down to the practice, and it makes practices evolve, and the relation with patients. I know that when it's about innovation, the industrials have something to say. Corinne, what do industrials? What are the means to approach AI or new technologies in your perspective? I would like to precise. The industrials are not called on to assess or to get into the initial training of professionals. That's not our job. That's very clear. Nevertheless, we can bring compliments on many topics and skills. So I'm going to take an example that I see in my labs that is close to the issue of management. We accompany a group of pharmacists in hospitals, in university hospitals, so heads of sections that need to talk about management and to benefit from our experience. And as industrials, we thought about the issue of decision-making, team development, performance management, how to build steering committees that take decisions. And they had a lot of questions. And we realized that we have a lot of common issues. When you manage big teams, you exchange we have similar examples that we share with the hospital world. And this is something that we can really share. And we can make them benefit from our own progress in this field. And you mentioned AI. Today, obviously, nobody can, in any field possible, and especially in health, can deny the importance and the transformation it's going to entail. So we carried out surveys, and we see that doctors, health professionals, radiologists, that are extremely favorable and positive, and have already integrated AI in their own practices through equipment, software, algorithms. So that's really but there's a big gap between this specialty and other specialties, like more clinical, that treat directly with the patient. So there's an issue of how to use AI in a beneficial way to free medical time to the benefit of human interaction. So AI, for us as industrials, we are thinking of how to use it in a positive way and broadly. And so we are learning. The idea is not to name an AI expert who's going to spread his knowledge, is to think of where AI can be useful with operational teams and then setting up projects. So this experience that has started, on which we're going to have we're going to start drawing lessons, and we can have interest of sharing that with professionals. But what was interesting in the use of new technologies, when we didn't oppose new technologies, the human on one side and technology on the other, but when we triangulate and you cross. I remember a great industrial who worked in nursing homes, who did experiments with small robots, but the robot could have the residents do exercises, but instead of following a coach in a thong, he would follow a robot. and so the little robot could adjust his motions to the ability of the residents to do the motions themselves. And so but there was a human beings present. What I think is interesting is that are we able not just to always oppose this in a dichotomic fashion? How do I use technology to add something, to give more, to free time, to have more exchange with the patient? Do you have examples? I think all of you are here at the table. Examples that correspond to this kind of use. I have more examples where we see that we wanted to focus on technology, and it was more on the ends than on the means. And so in the industry, some years ago, we were fond of application. We don't use them as well. And it didn't solve the problem of underdiagnosis, of subcontracting. And so evidently, it has to be a combination. This combination has to be well orchestrated by the professional, by the health professional. So it can be a doctor, a pharmacist, nurse. And so we're running tests right now. I don't have examples right now because we're in the experimental phase. Olivia, examples and other uses of technology, maybe for the training itself? In the training itself, on the emergence of new technologies in health, it's rather late in our training that it's dealt with, that it's talked about. And so in many sectors of health, according to their specialties, some professionals are not trained. And on the initial training, we probably lack. But it's something that we use and we should develop to improve access to training and access to care as well. We know that students have the tendency to start their practice, to go back to their place of origin, and we uproot them systematically to do their health studies that are in the great cities. It's complicated after to go back to where you came from. It's always the same issue. it's a snake biting its tail. With new technology, we could say, look, we could easily outsource the training, but today we do it very little. We do very little of it. The trainings today that are in initial training in the hospital, the university hospitals, we don't show it to them, and so it's hard for them to project themselves in a career, whatever it may be. Nobody projects themselves in a hospital linear career. They don't project themselves at all. Students today, in no kind of career path, any kind of career path. Just to give the floor to Rémi Salomon again, one word on technology. Do you fear that this technology will leave people uprooted, and we don't manage to have them work together, or it allows other things? So there's several questions. I'm going to answer one. AI and training, in health trainings. We had a seminary in my university with the presentation of a research project of a deputy clinical director that presented the use of an AI for conversation in the training with a system from a scenario that we give to we feed into the AI. So it was built with ChatGPT to have an exchange with on the simulation of a consultation and an interaction doctor-patient, and I think it's great. It's like this with the pilot this morning. The scenario was built by researchers and can answer meet the needs of the training. The bonus, Rémi Salomon, last, maybe I can be kind of original here. We're fascinated by new technology. It's normal, me too. I'm convinced that digital is transforming the way we practice medicine. I'm the first one to see that we don't invest enough to structure this kind of patient-doctor relation. For disciplines where imagery is important, yes, you have immediate benefit, and we see it transforms the practice. For the rest, I'm still think that practice of medicine needs people, humans, to have time. You need to value our time. We lack time to treat with our patients, and no machine will ever replace that. Digital is very useful for public health, to study data. We mentioned it. Relationship between a doctor and a patient is time, and that no machine can replace that. And we lack that. We lack time. That was the issue. Will technology allow? This is what it claims, is that it frees up time in order to have more relationship. You need medical files that work well, an IT that works well. If it works well, it's going to save us time. It's going to free up time. And when we ask hospital doctors, they say that the system doesn't work well. AI, I think there's a lot of fantasy around it. For the practice of medicine, apart from specialty where image is at the forefront, we're going to do some remote consultation. It's going to change things, but moderately. But it's not at the core. Very clear. So now we move on to the third part of our discussion that corresponds to all the systematic impacts of trainings. Isabelle, you have set up, you have brought to the table this topic. Tell us the main impact that you have seen, that you have observed. So, thank you. I think training, it's a major transformation lever of our system through two levers. The first, so the territorial approach to the training offer. I think that a medical university should give a quality professional training and good scientific content. And so the wealth of our training is based on that. And I think there's two says that are important in our field. Where I train, I will start my practice. As Olivia said, we should open internships. And in Montpellier, we did in Berger, in Alès, and in big cities where there's big hospital centers. By keeping universities centralized, send in territories trainees. We need to have professional associate professors in hospitals. We need more people to follow those interns and to have more of these young practitioners in territories. And on this issue of with the people that I train, I'm going to work with them. Okay, so you create a bond with the people who train you. And so they're in silos right now. We need to break those silos. Is that in the university, you can allow students that they're together at some point in their lives, that they eat together, that they party together, that they get to know each other, and that they have mutual respect. So this interprofessionality, from the start, that's going to work into the magic of what's going to happen later in the evolution of our health system. And the second lever is basically to bring into the university paramedical training. So it's a complicated word. We don't have representatives of paramedical trainings. So to upgrade their skills first, they gain autonomy. I think a skill is by training that you get it, that you learn it, and it's the opportunity to emerge new jobs for medical assistants, and to give access to these trainings that I think today it's 3 years with a degree. The access to not all doctors do a doctorate in science, but having a gradual approach to trainings and to have emerged a faculty in paramedical science. We have faculty in medicine. We need to have a real faculty on paramedical trainings. And that's a major level of transformation of the health system, because when we talk about medical deserts, which doesn't mean anything, it's not a question of desert. It's unequal access to care. It's a question of where are the doctors and the coordination of services in the territories. And so I think that, and I'm completely convinced of that, the evolution of this health system, training is a major level of transformation of the health system. Rémi SALOMON, one word. I'm completely in line with what was just said, and we're very attached to how the hospital universities, university hospitals are well rooted in the territories. And so break those silos. I'm favorable for that. And talking about the issue of deserts, to have nurses, about bringing them into a more university framework, we'll get to that later. The training itself should be well coordinated, and where they do their internships and the theoretical trainings. That is lacking. And we need a career perspective for nurses. Olivia, as user, I would say, of the system, the impact of training of our health system, why is such a lever? I think training is not so much, we really need to to ask the question of the relevance, and that's the key word to this year. If it's relevant, why do we continue doing training? There's a paradox. Our studies get longer with reasons that are not always good, I would say, and fallacious. I wouldn't mention the fourth year, but the fourth year of general medicine, They have no university argument or need. Interns don't have access to initial training. It's not given access to them. They're health professionals. And for all health professionals, there's no time for training. And you said it. There's no time for training, for continuous training. And I think there's an issue today. How can we transform training so that it participates correctly, adequately with the health system? How can young people get trained to practice that they want and that they don't get locked in or captive of the health system for fallacious reasons that they're not ready, when in reality, for interns, well, the only doctors to have certain services run, they're deserted by those who are supposed to work there. We get to our conclusion. Corinne, what should we, what would you emphasize on? I'm going to speak. We wish to, as industry, we wish to contribute positively to collective interest projects. During COVID, for instance, when everybody was locked in my lab, helping train. We all found ourselves in front of screens, and there were a lot of remote consultations, and we didn't interact in the same way when we were in front of a screen. And it was something that was very useful for specialists. We have, from our experience as for management, a lot of things that we draw from new technologies, digital and AI, that can be useful for the health system and for professionals, and can be deployed, that can be rolled out into the health system. Isabelle, your last word. The excellence of trainings. Everybody has the right to grow. Keep big universities. Keep the big universities. Interprofessionality is key. Convinced, as I am, territorial issue, territorialization, and the essential role of initial and continuous training. Olivier said it well. There's a little issue in terms of knowing that they have normally 1 day normally given for trainings for interns. Normally you have 1 out of 5, and this is not respected, and that's not good. Rémi SALOMON, your last word? From continuous training for nurses, career perspective. We were very late compared to the Anglo-Saxon countries. We have difficulty rolling this out. A nurse, when it starts a career, they have to have milestones and perspectives in their career. Second thing, break the silos between hospital doctors and city doctors. The patient run and the doctors don't know each other. And last point, I would like to say to Olivia, we don't project ourselves anymore. It's hard to hear, but we need that young people who start in this career need to project themselves. And we have to think about it, and we're going to need to work on it. But we have to go beyond that. And that young people, and people who are not as young, work together. And see how we can train young people for tomorrow. This is essential. The young people need to project themselves. And we need leadership, as you all showed. Thank you. 33 seconds late.